Hello my dear friends. Now, as a part of the continuation of ECG lecture series, in this session I will be discussing the pre-excitation syndromes. So, the pre-excitation syndromes are the abnormalities associated with the PR interval. So, in my sections of the PR interval, like I have discussed, the clinical scenarios where you will have prolonged PR interval. That is mainly in case of AV block. In case of first degree AV block, second degree AV block, third degree AV block, you will have prolongation of the PR interval. But whereas in case of the pre-excitation syndromes, you will have short PR interval. Okay, so that's a very important feature of the pre-excitation syndromes. Now, what are the examples of the pre-excitation syndromes? That includes the following. Number one, the Wolff-Parkinson-White syndrome. And the second one is Lown-Ganong-Levine syndrome. So these are the two important pre-excitation syndromes. Now, what is the importance of these pre-excitation syndromes is, in these individuals, between the SA node and AV node, apart from the internodal fibers, in between SA node and AV node in the conducting system, we have anterior, middle and posterior internodal fibers. Now, apart from anterior, posterior and middle internodal fibers, in these individuals with the pre-excitation syndromes, they have an accessory pathway. Right, they have the presence of the accessory pathway. Now, this particular accessory pathway, they connect the atria directly to the ventricle without the connection of AV node. Normally, the atria is connected to the ventricle through the AV node. But in case of the presence of the accessory pathway, atria is directly connected to ventricle through this particular accessory pathways. Now, let me show you that. So, if you see this particular image over here, this is your SA node, this is your AV node, and you have the anterior, middle and posterior internodal fibers. And apart from that, this is your accessory pathway. Right, this is your accessory pathway. So now, because of the presence of this particular accessory pathway, what will happen is, the impulse from atria to the ventricle is transmitted prematurely. Normally, your AV node, right? Normally, the AV node, it acts as the speed breaker for the transmission of the impulses. Now, if there is presence of the accessory pathway, the impulse from SA node directly enters into the ventricle without the intervention of the AV node. So thereby, what will happen to your PR interval? The PR interval will be shortened. Right? The PR interval will be shortened. What actually the PR interval represents? The PR interval, it represents the time taken for the impulse to move from SA node to the AV node and through the AV node. That is what is the PR interval. But here, in the presence of accessory pathway, there is no intervention of your AV node now. When there is no intervention of the AV node, the impulse will directly jump into the ventricle. So thereby, what will happen to your PR interval? The PR interval will be shortened. Now, the point here that you should understand, what is the normal PR interval? Normal PR interval, it is around 120 to 200 milliseconds. So when you are using the term short PR interval, it will be less than 120 milliseconds. Right? It will be less than 120 milliseconds. So that is what is your short PR interval. Now, this particular we have two important syndromes now, pre-excitation syndromes, Wpw syndrome and as well as Lown-Ganong-Levine syndrome. So first, let me take up the discussion of the Wpw syndrome and later let me take up the discussion of Lown-Ganong-Levine syndrome. Now, you take this particular multiple choice question. Most common cardiac anomaly associated with the Wpw syndrome: tetralogy of Fallot, Epstein's anomaly, ventricular septal defect, the coarctation of aorta. So the most common cardiac anomaly associated with the Wpw syndrome, the answer in this question is Epstein's anomaly. So in Epstein's anomaly, there is high chances of the presence of the accessory pathways, and that makes the individual to develop what is called the Wpw syndrome. Now the question is, what is your Epstein's anomaly? Right? What is your Epstein's anomaly? That is, Epstein's anomaly is a clinical condition where you have distal displacement of the tricuspid valve. Right, where you have distal displacement of the tricuspid valve, and thereby there will be atrialization of right ventricle. Right, thereby there will be atrialization of the right ventricle. That is called as the Epstein's anomaly. Right, now after having discussed about the conditions where you will have this particular Wpw syndrome, let me tell you some of the very important features of your Wpw syndrome. So, if you see this Wpw syndrome, the incidence in the general population, it is around 0.123. Right, the incidence is around 0.123%. And if you take the prevalence of this Wpw syndrome, the prevalence, it is higher in males than compared to that of the females. And the next important point regarding Wpw syndrome, it is an inherited disorder, and the type of inheritance is autosomal dominant type of inheritance. Right, autosomal dominant type of inheritance. Now, what are the associated cardiac defects reported in these patients with the Wpw syndrome? The associated cardiac defects reported in these patients with the Wpw syndrome includes, number 1, Epstein's anomaly. Right? Number 2, mitral valve prolapse. 3, cardiomyopathies. So these are the conditions where you have the association of the Wpw syndrome. Okay. So in Wpw syndrome, what do you have? You have ectopic AV conducting system. Right. There is presence of an ectopic AV conduction pathway. Okay. So the incidence is around 0.123. The prevalence is more in males. Autosomal dominant type of inheritance. And the cardiac defects associated are Epstein's anomaly, mitral valve prolapse, and cardiomyopathies. And in Wpw syndrome, there is presence of an ectopic AV conduction pathway is being present. Now, the point what you should understand is, you see, this is your Wpw syndrome, where you have the presence of the accessory pathway. Now, this accessory pathway can be on the left side, or the accessory pathway can be present on the right side. Now, either it is in the right side or on the left side. It can be present in the left lateral wall. It can be present posteriorly. It can be present anteriorly. It can be present laterally. Now, accordingly, you see a very important multiple choice question. Right. So the question is, most common accessory pathway leading to Wpw syndrome is, the options are left free wall, posteroseptal, right free wall, anteroseptal. So where exactly is the location of this particular accessory pathway? The most common accessory pathway leading to Wpw syndrome, it is present in the left free wall. Now, you should also know what is the name of this particular accessory pathway. Okay. So, the name of this accessory pathway, it is nothing but the bundle of Kent. Right? It is nothing but the bundle of Kent. Now, if you take this accessory pathways, what did I tell you? They are present on either on right side. they are present either on the left side. Now accordingly, you see the classification. Like for example, you take left-sided pathways, right? You take left-sided pathways. So left-sided pathways are those like where you have the bundle of Kent into left atrium and as well as the left ventricle. Now where all you can have this particular left side also, in the left side, you can have it posteriorly, you can have it anteriorly, and in the posterior again, you have posterolateral or posteroseptal, and anteriorly the anterolateral, right? Anteriorly anterolateral. So these are the location of the left-sided pathways. Now coming to the right-sided pathways. So if you see the right-sided pathways, they are located here. That is, on the right side, it can be present in the septal, right? It can be present in the septal, or it can be present in the free wall, right? Or it is present in the free wall. And if you take septal, within the septal where it can be present, that is posteroseptal, mid-septal, anteroseptal. That is in the right-sided septal pathways, in the posteroseptal or mid-septal or anteroseptal. So if you see the right-sided free wall, it can be anterolateral or it can be the posterolateral. So these are your right-sided pathways. So in your right-sided pathways or in the left-sided pathways, what is the most common accessory pathway leading to Wpw syndrome? It is the left free wall. Now you see the next question. Wpw syndrome is caused by bundle branch block, right-sided accessory pathway, ectopic pacemaker in the atrium, left bundle branch block. So remember, you should not get confused with right ectopic pacemaker in the atrium. Your Wpw syndrome, it is your accessory pathway. It is not an ectopic pacemaker within the atrium. Okay, so please remember that, very important. Now, if you see the Ecg findings in case of the Wpw syndrome, the question is, all of the Ecg findings in Wpw syndrome are present except, right? All are the Ecg findings in Wpw syndrome except narrow Qrs complexes, normal QT interval, slurred and tall Qrs complex, short PR interval. Now, what is the Ecg feature that you will not see in the Wpw syndrome? That is what is the question. The answer here is, you will not have the narrow Qrs complex in Wpw syndrome. In Wpw syndrome, you will have the presence of wide Qrs complex. Right? You have the presence of the wide Qrs complex. Now, why is that? Let me explain. So, if you take the cardiac activation in Wpw syndrome, it takes place in 3 sequential phases. And that particular 3 sequential phases include, 1 is your atrial activation, 2 is your ventricular pre-excitation, and 3 is the terminal ventricular activation, right? Terminal ventricular activation. So these are the 3 sequential phases in the cardiac activation. Now, accordingly, like what will be the manifestations of the Ecg? Let me tell you. So first of all, atrial activation, you have the presence of the P wave, right? So this particular P wave is due to the atrial activation, right? It is due to atrial activation. And subsequently, you see here, you have the presence of the delta wave. And why is that you have the delta wave? Why? Because you have the presence of the ventricular pre-excitation. It is not that SA node impulse is going to AV node is sending the impulse to the interventricular septum. That is not the pathway in Wpw syndrome. In Wpw syndrome, ventricle is exciting first, then compared to your interventricular septum. And that is the reason why you see you don't have the Q wave also. When will you have the Q wave? You will have Q wave when there is depolarization of the interventricular septum. But here, before the depolarization of the interventricle, so you will not have the Q wave. Why? Because the ventricle is directly getting depolarized from the accessory pathway without the interventricular septum being depolarized first. Actually, your Q wave is due to interventricular septal depolarization. And here, in case of the pre-excitation syndromes, the impulse to the ventricle is not reaching through the AV node initially. And that is the reason why you will not have the Q wave. First, the ventricular wall gets depolarized. Now, the point that you should understand here is the ventricle is getting depolarized through the accessory pathway. For suppose, if the ventricle is getting depolarized through the internodal fibers, AV node, bundle of his, right and left bundle branch, then in such case, you will have the normal Qrs complex. Right? You will have the normal Qrs complex. But what is happening here? The ventricle is depolarizing through the accessory pathway. So when the ventricle is depolarizing through the accessory pathway, what will be the velocity of the conduction of your ventricular depolarization wave? The velocity of the conduction of the ventricular depolarization wave will be very slow compared to that of the velocity of the conduction through the conducting system, that is bundle of his and as well as right and left bundle branch. Now, the point that you should understand is the QRS complex in these individuals, they will be wide. Right? It will be wide. Why? Because the velocity of the conduction of the impulse passing through the ventricle is very slow. Thereby, there will be a slow ventricular depolarization and thereby you will have a wide QRS complex. So, if you take the QRS here, there will be QRS prolongation of more than 110 milliseconds. And the next important thing is your delta wave. What is this delta wave? So, this is your delta wave. Delta wave, it is nothing but slurring, slow rise of the initial portion of the QRS complex. Right? Slurring, slow rise of the initial portion of the QRS complex. That is what is called as the delta wave. And why is that? That short PR interval, whatever is there, is reflected onto the QRS complex. And that is being represented as the delta wave. And what will happen to your ST and as well as the T wave? You have the discordant changes. Like for suppose, if the QRS complex or if the ST segment is positive, then the T wave will be inverted. So, ST segment and T wave, they will have discordant changes. Right? They will have discordant changes. That is in the opposite direction to the major component of the QRS complex. Right? So, the T wave, it will be always in the opposite direction to the major component of the QRS complex. That is what you will see in case of the pre-excitation syndromes. Okay. So, to summarize the Ecg features in case of the Wpw syndrome, due to atrial activation, you will have P wave. And due to ventricular pre-excitation, you will have short PR interval, wide QRS complex and the presence of delta wave. And due to terminal ventricular activation, you will have discordant changes. There will be discordant between the ST segment and as well as the T wave. Okay. Now, let me show you the ECGs. Now, if you take this particular ECG, let me tell you that the present classification of the pre-excitation syndromes is like just now I have shown you, left-sided pathways and as well as right-sided pathways. Previously, they used to classify the pre-excitation syndromes as type A Wpw syndrome and as well as type B Wpw syndrome. So that is what they used to classify previously, type A and as well as type B. Now the question is, what is type A and what is type B Wpw syndrome? Type A Wpw syndrome is that where the individual will have left-sided pathways, right, where the individual will have left-sided accessory pathway. So that left-sided accessory pathway, it is your type A Wpw syndrome, right? Now, in case of your left-sided pathways, which is nothing but your type A Wpw syndrome, what will be the Ecg changes or what will be the Ecg features? In case of type A, where you have left-sided pathways, you have the presence of dominant R wave in V1. Right, you have the presence of dominant R wave in V1. And along with that, you have the same other things like the presence of short PR interval, right, and the presence of the delta wave. All that as usual. But how to identify the left-sided pathways? How to identify the left-sided pathways is by the presence of increased R wave amplitude in lead V1 and as well as in lead V2. And what did I tell you regarding the T wave? I said you that the T wave will be exactly in the opposite direction of the QRS complex. You see here, the QRS complex is positive and the T wave, it is negative. Okay, so that is what is your left-sided pathways. And in right-sided pathways, exactly reverse. That is, now you take this particular ECG. In this ECG, you are able to make out everything. What is that? You are having short PR interval, right? And if you take the QRS complex, it is wide QRS complex, right? And you are also able to make out that there is presence of a minimal slur, right? There is also a slurring of the upslope of the QRS complex. And what is that called? That is nothing but your delta wave. Right, that is nothing but the presence of the delta wave. Now, if you take this particular pre-excitation syndrome here, this we call it as an ECG with right-sided pathways, which previously they used to call it as type B Wpw syndrome. So, what you should understand, type A Wpw syndrome, that is your left-sided pathways. And in left-sided pathways, how will you identify? You will have dominant R wave in V1, V2 and with T wave inversion. Whereas in right-sided pathways, if you see, you will have negative QRS complex in V1 and as well as V2, right? So you will not have a dominant R wave in V1 and as well as V2. But the other features of your Wpw syndrome like short PR interval, wide QRS complex, the presence of the delta wave, all that will be there. So now the point you should know or you should understand here is that in type B Wpw syndrome, you will have a negative QRS complex. Okay. Now what did I tell you? The T wave direction will exactly be opposite to that of the QRS complex. Okay. You see how is the QRS complex? It is negative. And how is your T wave? T wave, it is positive. Right, the T wave, it is positive. So that is what is your type B Wpw syndrome. Okay. Now, let us just go back to the same multiple choice question what I was discussing previously. So this was the question. All are the Ecg findings in Wpw syndrome except narrow QRS complex, normal QT interval, slurred and tall QRS complex, short PR interval. Short PR interval, yes, it will be there. Slurred and tall QRS complex will be there. And you will have a normal QT interval. But the point is, they will not have narrow QRS complex. What they will have is a wide QRS complex. Right? What they have is a wide QRS complex. Okay. So, why there will be wide QRS complex? I have explained you. Because the ventricular depolarization is not through the depolarization from your bundle branches, not through the depolarization from the normal conducting system. The ventricular wall depolarization is through the accessory pathway, and the velocity of the conduction within the ventricular wall will be very slow, and thereby you will have a wide QRS complex. Right? Thereby you will have a wide QRS complex. Okay. Next, followed by that, what will be the clinical features in these patients with the Wpw syndrome? So if you take the clinical features in patients with the Wpw syndrome, in Wpw syndrome, you will have a very faster heart rate. And that gives an impression of tachycardia. So when there is tachycardia, what do you think will be the clinical manifestations? These individuals, they'll have the clinical manifestation, that is palpitations. Right, that is palpitations. Palpitations are the important clinical manifestations in these individuals. Why? Because of an abnormal extra electric pathway into the ventricle. Now, the next thing is, the individual is having tachycardia, and how is your ventricular depolarization? The depolarization is happening, but it is an incomplete ventricular contraction. So, the rate is high, but the contraction is not a complete contraction. Because the rate being very high, the ventricle will just contract, will just give you a flickering of contractions. So thereby, what will happen to your cardiac output? Right, see, actually cardiac output is heart rate into stroke volume. That is a formula. The heart rate is increased, that is very much accepted. But what will happen to the stroke volume? Stroke volume is grossly reduced because it's an incomplete contraction there. So the cardiac output ultimately reduces. When the cardiac output ultimately reduces, these individuals, they can have multiple manifestations like dizziness, or they can have the presence of lightheadedness, they can have the fainting spells, right? They can have the fainting spells, and some of the patients with Wpw syndrome, they are like picked up accidentally. They don't have any symptoms at all. Okay, and the other extreme end of the manifestation of Wpw syndrome is there can be also family history of a sudden cardiac death. Right, family history of sudden cardiac death is also present in these patients with the Wpw syndrome. So, to summarize the manifestations, they'll have palpitations, dizziness, lightheadedness, faintness, and family history of sudden cardiac death can be present. Now, how do you treat these patients? See, we have medical management and we also have the non-pharmacological management. What is that? I'll tell you. You see the question. The question is, drug of choice in Wpw syndrome is flecainide, ibutylide, amiodarone, then lignocaine. Right, then lignocaine. The answer here is flecainide. Flecainide is considered as the drug of choice in these patients with Wpw syndrome. See, these patients with Wpw syndrome are treated because of symptomatic arrhythmia, or there is risk of life-threatening arrhythmias in these individuals. See, if the individual is asymptomatic, right, there is no treatment which is required. But if the individual is symptomatic, right, if the individual is symptomatic, that is the point when you have to treat for life-threatening arrhythmias. Right, that is the point when you have to treat for the life-threatening arrhythmias. Okay, and what is the treatment you will give there? That is your flecainide. Okay, so in the treatment we have two options. One, the non-pharmacological therapies are there and pharmacological therapies are also there. Okay, so the treatment options with arrhythmias and Wpw syndrome include non-pharmacological therapies and as well as the pharmacological therapies. Now, what are the non-pharmacological therapies? That is, what is the treatment of choice? The treatment of choice in these patients will be catheter ablation of the accessory pathway. That is a treatment of choice. That is a non-pharmacological therapy, right? So you will do what is called radiofrequency ablation of that particular accessory pathway. And pharmacological therapy, that is mainly to prevent or to slow the ventricular rates or to prevent the arrhythmia, right? And the choice of the optimal therapy depends on the acuity of arrhythmia and the risk of the sudden cardiac death. Okay, so non-pharmacological therapy, radiofrequency ablation or catheter ablation of the accessory pathway. Pharmacological therapy, that is mainly to slow down the ventricular heart rate or to prevent the arrhythmias. And what is the drug of choice? That is your flecainide. Now, all the patients with an arrhythmia involving an accessory pathway should have a prompt initial assessment of the hemodynamic status. Why? Because if the individual is hemodynamically unstable, whatever might be the type of the arrhythmia, these individuals should undergo urgent electrical cardioversion. Right? These individuals, they have to undergo urgent electrical cardioversion. So that is the treatment if the individual is hemodynamically unstable. Right? Next. Now, for suppose if the individual is having symptomatic orthodromic AVRT, like we have antidromic AVRT, right? I will be discussing this again in detail in the topic of the arrhythmias. What is AVRT? That is atrioventricular reentrant tachycardia. Right, atrioventricular reentrant tachycardia, that is called AVRT. Now, you take the orthodomic AVRT. Orthodomic AVRT is the clockwise transmission of the impulse from the atria to the ventricle. And so please don't worry of this word orthodomic at this point of time. You can just go through my sections on the arrhythmias, that is atrial arrhythmias. There I have discussed in detail about the AVRT and AVNRT. There I have discussed in detail about orthodomic and as well as antidromic AVRT. But for now, just remember, in symptomatic orthodomic AVRT who are hemodynamically stable, the following approach is required. What is the initial treatment for your AVRT? The initial treatment, you need to give the vagal maneuvers. Right? Vagal maneuvers is recommended rather than the pharmacological therapy. That is the initial treatment. Right? That is the initial treatment. For suppose, if the vagal maneuvers are ineffective, then you need to give AV nodal blocking agents. That includes adenosine, verapamil and beta blockers. Now, why are we discussing the point of AVRT here? Remember, Wpw syndrome can be one of the cause for your AVRT, atrioventricular reentrant tachycardia. That is why I am discussing the topic of AVRT at this juncture of the Wpw syndrome. Alright, next. Now, ultimately, to summarize the treatment, drug of choice is flecainide and the treatment of choice is the radiofrequency ablation. So this is about your Wpw syndrome. So I said you that we have two pre-excitation syndromes. One, Wpw syndrome. Two, Lown-Ganong-Levine syndrome. and both of them, they are like inherited disorders. Wpw syndrome, autosomal dominant type of inheritance, more common in males. And the name of the pathway is the accessory bundle of Kent. And you can have right-sided pathways and left-sided pathways. But the most common is the pathway on the left side. The left free wall pathway is more common than compared to that of the right-sided accessory pathways. And what will be the Ecg manifestations? P wave will be normal, the PR interval will be shortened, the Qrs complex will be wide, and you have the presence of the delta wave, and the T wave, it will be opposite to the direction of the Qrs complex. And what is the previous classification? Type A and Type B Wpw syndrome. Type A Wpw syndrome, that is your left-sided pathways. So in left-sided pathways, what will be the Ecg manifestation? You will have a dominant R wave in V1 and as well as V2. Whereas type B Wpw syndrome, that is your right-sided pathways. And in right-sided pathways, you will have negative Qrs complex in the V1 and as well as V2. That is your type A and type B Wpw syndrome. So this was the previous classification, but the present classification is right-sided pathway, left-sided pathway. Left-sided pathway, again it is subdivided. Right-sided pathways are also again subdivided. Next, following that, like we have discussed the clinical manifestations. Some of the patients, they may remain asymptomatic. Some of the patients, they may come with a family history of sudden cardiac death. And some of the individuals, they can have this tachycardia causing palpitations. Palpitations will be the presenting symptom. And some of the individuals, let me tell you, they can present with the dizziness, fainting attacks, syncopal attacks, and they can present directly with the sudden cardiac death. These are all the various presentations of the Wpw syndrome. And how do you treat these patients? Pharmacological treatment, drug of choice is flecainide. Why are you very much worried? Why you want to give flecainide? You want to reduce the ventricular rate. You want to reduce the development of that ventricular arrhythmia. And finally, the treatment of choice is you do a radiofrequency ablation of that particular accessory pathway. Right? That is the treatment of choice. And this Wpw syndrome is can be one of the cause for AVRT. And if these individuals develop AVRT, the first line management will be vagal maneuvers. And if the vagal maneuver fails, then we give adenosine, verapamil or beta blockers can be given. So that is about the Wpw syndrome. Now let me discuss the next important pre-excitation syndrome, that is Lown-Ganong-Levine syndrome. So if you see this Lown-Ganong-Levine syndrome, the question is, LGL syndrome is inherited as autosomal dominant, autosomal recessive, X-linked recessive, and it's an acquired condition. So let me tell you, the Lown-Ganong-Levine syndrome, it is inherited as an autosomal recessive condition. Wpw syndrome, autosomal dominant condition. Lown-Ganong-Levine syndrome, autosomal recessive type of inheritance. Now, what is the name of this particular accessory bundle in these patients with the Lown-Ganong-Levine syndrome? So this is also a pre-excitation syndrome, means there should be a presence of an accessory pathway. So Lown-Ganong-Levine syndrome, the accessory pathway what we have here is bundle of James. Or this is called as Maham's fiber or Maham's bundle. Right, Maham's fibers or the Maham's bundle. So that is what is the Lown-Ganong-Levine syndrome. That is in the name of the accessory pathway. Now, if you see here, like how will be the accessory pathway here? In case of Lown-Ganong-Levine syndrome, the accessory pathway will be from SA node, directly it will jump onto the bundle of S without getting connected to the AV node in between. Let me show you that. So, this is your SA node, this is your AV node. In case of the Lown-Ganong-Levine syndrome, the accessory pathway it will be from the SA node and directly it will be connecting to the bundle of S. You understand that? So, what will be the Ecg features now? The only thing, this particular accessory pathway is bypassing your AV node. and thereby causing the pre-excitation. See, actually AV node, it acts as a speed breaker for the impulses which are coming from the SA node. But because of the presence of the accessory pathway, that speed breaker is gone. And thereby the ventricle will depolarize earlier than the normal time. That is the reason why it is called the pre-excitation syndrome. Now, the ECG features are that they will have the normal P wave because your atria is depolarizing normally. And you take the QRS complex. The QRS complex also will be normal. What did we discuss in case of the Wpw syndrome? The QRS complex will be wide, but here the QRS complex will be normal. It will not be wide. Now, why the QRS complex will be normal? Because the ventricle, it is getting depolarized through your internodal fibers only, through your bundle branches only, right? The ventricle is depolarizing through the bundle branches only. Why? Because the accessory pathway, it is connecting to the bundle office, right? It is connecting to the bundle office. So from the bundle office, where will the impulse go? The impulse will go to the bundle branches, and accordingly the ventricle will depolarize. So the velocity of the conduction will be as usual, like what we have in a normal heart. But only thing, what is the abnormality then? The PR interval, right? The PR interval will be shortened, right? The PR interval will be shortened. So why the PR interval will be shortened? Because the impulse is not passing through your AV node. The impulse is directly jumping onto the bundle office. So that is the reason why the PR interval will be shortened. So in case of Lown-Ganong-Levine syndrome, they will have a very short PR interval with normal P wave and normal QRS complex. And you will not have the delta wave. Like whatever we see in the Wpw syndrome, you don't have the delta wave. And the name of the accessory pathway is bundle of James or the Mahane's fiber. And this is a pre-excitation syndrome. And the type of inheritance we have seen, autosomal recessive type of inheritance, right? And these individuals also, they have low cardiac output. Why? Because they can have the development of the arrhythmias, because the ventricle is undergoing pre-excitation. So they can have this particular arrhythmias. Once these individuals have arrhythmias, they can have the low cardiac output state. Now, because these individuals are having arrhythmias, so what do you think is the clinical manifestations? The clinical manifestations in these individuals will be in the form of palpitations, right? Will be in the form of palpitations or the dizziness. And in these individuals, they will also have recurrent syncopal attacks. Right? They have recurrent syncopal attacks. And they also have the family history of sudden cardiac death. Right? And what is the treatment? The drug of choice is the flecainide. And the treatment of choice is your radiofrequency ablation. Okay. So before that, let me just show you the ECG also at the same time. So this is the ECG of your LGL syndrome. So if you see here, the P wave, it is normal. Right? So normal P wave. And how is your QRS complex? Even the QRS complex is also normal. Then what is the abnormality? That is your short PR interval. Right? So this is not the ECG of the same. Right? So they will have the short PR interval. That is the ECG change like what you will have in patients with the Lown-Ganong-Levine syndrome. So what will be the clinical manifestations? Palpitations or dizziness. They can have recurrent syncopal attacks. They'll have family history of sudden cardiac death. Treatment is oral flecainide, and the treatment of choice will be radiofrequency ablation. So this is about the Lown-Ganong-Levine syndrome. So two important pre-excitation syndromes, Wpw syndrome and LGL syndrome. To summarize the ECG changes, in Wpw syndrome, you will have normal P wave, short PR interval, delta wave, wide QRS complex, and T wave will be exactly in the opposite direction of the QRS complex. LGL syndrome, normal P wave, short PR interval, and normal QRS complex. And both of these patients, the presentation will be in the form of arrhythmias. They can have sudden cardiac death. And in both of them, the treatment of choice will be radiofrequency ablation. So with this, I complete this topic of the pre-excitation syndromes. Thank you very much.